Well, Dr. Jaz Gulati, welcome to the Graduate Dentist Podcast.
Erica, it's an absolute pleasure to finally sort of have this time with you, to see you smiling at me in the flesh and your energy, your vibe. We're cut from the same cloth, right? You know, we're there to explore with guests. We're sharing ideas. We're learning. Don't you learn so much from speaking to these guests? And the privilege to be able to share it with our colleagues is amazing.
Yeah, well, no, I feel like for me, this is almost a bit of a surreal experience to see you actually talking to me live and not that it's not something pre-recorded that I'm watching off Instagram or off your podcast. And so I think the honor is mine, but I think both of us are going to be very geeky from one podcaster to another. As you said, we come from the same world. We both geek out over being able to just, continue to talk dentistry with all these people in our industry now across the world, right? I feel like this is the furthest I've been able to interact with someone from all the way across the world. And just
have you had a Brit yet? Is it the first Brit?
No, this is the first one. You're the first one.
Okay, sweet. I'll try and wave the flag as best I can.
Well, Jaz, you said to me that you think this is going to be the best podcast on occlusion that's going to be out on the internet. So I feel like it's an absolute honor to have you share that with our audience. And I don't feel like you need much of an introduction. Everyone will surely know. I think you've been in the dental industry for so long, sharing all your knowledge, being so generous and really, I guess, setting a standard for just dental education that's easily accessible for everyone out there. But a question that I have for you is, perhaps before we dive into all the meat of this episode, is when I started the Graduate Dentist, something that took me the longest time and perhaps held me back from starting this was deciding on a name. And so I wanted to ask you, how did you come up with the Protrusive Dental Podcast and what sparked you starting it?
That's a great question, because the podcast when it initially started was nothing to do with occlusion. Like at that phase of my life, I knew I liked occlusion, but it wasn't like at the forefront of my mind and that kind of stuff. So I just wanted something. I actually started with, okay, what do I want this podcast to be? I never knew it would actually make it past episode 1. Like I just thought, I just want to do one episode, because I moved to Singapore. I moved back to the UK, and at one stage, I felt like every single UK dentist had my phone number. And as I was doing my 50-mile commute every day, which I'm sure you Aussies do all the time, every dentist was on the phone to me asking the same questions, like how much do you earn in Singapore? Do I need to do any exams? What's it like? Is it too humid? All these questions. And I thought, is there a way I can just do a voice note and just send it to everyone? Because I want to get back to listen to my audiobooks, right? It was very selfish. So okay, there's things called podcasts, right? As someone who wasn't even listening to podcasts, I was like, all right, let me just stick one on. So I needed a name, and I thought, okay, in case this does have legs in the future, let me think of something, what could say forward thinking? I said, protrusive, it just went with that basically. So that's how it was born. The first episode was Singapore. The second episode was like USA. Fourth episode was Australia, actually, right? Like moving to Australia from the UK. And then from there, I was like, hang on a minute. How about I talk about the things that I like to talk about, which is restorative and eventually occlusion and that kind of stuff. So it's funny how these things come along. How about you?
For the longest time, I was stuck on this name. But for me, I think having been podcasting for a little while, I was previously on another podcast, but I realized that my area of passion was very much helping out new grads and representing the graduate community and representing students transitioning from being a student into a dental clinician. And I realized, I'm early on in that journey, but that was what stuck for me. For the longest time, I thought when I was podcasting, I saw myself as just the facilitator, as someone who I am here to ask questions from the expert, right? And then I realized that what people really clung to was my journey being a student, and then my journey being a new grad, and now being a graduate dentist. And I realized that's where I'm passionate. That's what gives me drive. That's my why. And so that then brought out into, I was just like, let's just keep, I thought it was my brother that helped me with the name. He's like, just keep it simple. The graduate dentist, that's your audience. That's the area that you're passionate about and what you advocate for. So yeah, there we go. Hey,
lovely.
Well, you said that it evolved. It didn't initially, your podcast wasn't initially about occlusion, but it evolved into being that. And this now becoming something that you're super passionate about, that you talk a lot and you help break it down and distill it into really just easable, bite-sized, right? Content for people. What have you got? What have you got to share with us today, Jaz?
I want to talk about, and the title I want to discuss with you is, as we talked beforehand, is Pareto's philosophy of occlusion. Are you familiar with the Pareto principle?
No, tell me about it.
The Pareto principle is actually nothing to do with occlusion. Okay, you might have heard of it. You might know it already as the 80-20 rule. Do you know about that?
Yeah. I think it applies perhaps to other things.
Everything, like everything
Yeah.
in life. Okay?
Okay.
Everything in life. Okay. So 20% of your effort, right, gives you 80% of your results. So for example, 80% of your complaints in a practice will come from 20% of the same patients, for example, right? 80% of your income will come from 20% of the procedures that you do. You could apply it to literally everything. And so to cut to the chase, when it comes to Pareto, how can we apply it to occlusion and learning, right? Is I strongly believe that 80% of the sort of occlusion confusion can be solved by just these 20%, these like small things. And really, I just want to talk about 5 things today, starting single tooth and working up to OVD increase, that kind of stuff that scares people. And I want to just talk about this in the lens of a little basic thing you can do that can actually leverage and have a really big practical advantage for you as a dentist.
I love that, because I think I came to you, Jaz, being like, Jaz, I need to talk to you about occlusion, because I think I think every dentist goes through that phase of when occlusion just becomes really overwhelming and you start just slamming your head against the wall and just being like, why doesn't it work and why doesn't it make sense? And you take a deep dive into the world of occlusion and people throw all these terminology at you and this concept, and you have to check this and you have to check that, and you're like, I just want someone to explain it simply, and how much do I need to do? And I love that you just came to me and you're like, you know what, like 80% of these things can solve. What was it that, how do I phrase that, right? 20% of things can solve 80% of these issues that you have. And I think for a new grad, that makes it a lot less daunting, because it means I don't necessarily have to do every nitty detail thing out there, but what are the main takeaways that I can implement just to help me get through my day-to-day and help me solve a lot of these common issues that we have.
Well, you used the word overwhelm, and I was going to ask you, like, what words, when I say occlusion, what words would you affiliate with occlusion? What comes to mind?
Overwhelming is definitely one of them. I think complex. I think predictability is something that I think for me, I'm struggling with. And I'm trying to build my like workflow and understanding of like, what things do I need to check off so that I know that this bite is going to be stable and it's going to be predictable. I am sick. You know what, Jaz? I am sick of finishing a filling for a patient or finishing a crown and just being like, let's see how we go. You won't know until you take it for a test drive and you go and eat and chew on some things. If there are any problems, come back, we'll adjust it. Like, I'm sick of doing that. I want to be able to just
You need protocols. That's what you said. Yeah. You said the steps and predictability. What you're saying is protocols. Now, all those words you said, absolutely. And so when I speak to general dentists all the time, we teach on this stuff, and we go around, we ask, what do you think of occlusion? Alongside the words you said, cult, mumbo jumbo. Some people say boring, okay? Some people actually say this is boring, okay? Now, when I go to my mentors and some of the most, like you put in a room, like at the AES, American Equilibration Society, right, in Chicago. I went a few years ago. I'm going again to present in February. And when I go to these guys who are just like, you know, people like Frank Spear, John Coyce, Michael Mokas, all my heroes are there, right? And I go around the room and I ask, like, just play along with me here, right? When I say occlusion, what do you think of? They use the words predictable, fun, and then they do success, longevity, okay? And if you ask me, if I was to start off with like, you know, 1 or 2 words that I think of all the years of studying inclusion and being obsessed by it, if I was to really break it down for a new grad, I would say occlusion is force management. If you can just manage the forces, except, you know, for example, you don't want to leave that single crown proud because that's a disproportionate amount of force going through that crown, which may increases your risk of something not working. But the most amazing thing, Erica, about the masticatory system is our ability to adapt. And one thing that we teach is there are HORPs and there are LORPs. Have you heard of this term before?
No, what is that? Is that a UK thing?
You won't find it in any textbook anywhere. It's something that me and Mahmood made, right? And all it is, okay, and then you'll realize where there's a P, right? It's low occlusal risk patients and high occlusal risk patients. Now, you need the P in there, otherwise it's laws and whores. So it has to be LORPs and HORPs, okay? And the main reason we go down that approach is everything we do is risk assessment. Everything we then apply is force management when we get things to work. And essentially, when you're dealing with a LORP, you can do things like make those little mamelons in your composites. You can make a delicate anatomy. You can get away with a lot. Your bond strengths may not have to be that good. Like you've seen patients, right? And they have these like GICs that are huge, and you look at it and you think, how on earth has this been there for 20 years, right? And you think, what's going on? Whereas on another patient, you have a really well-bonded composite, use all the protocols, air abrasion, whatnot, and they can bust it off in a few weeks. And so there's HORPs and LORPs. Now, I'm not saying occlusion is the only reason, but force management plays a big role in that. So I want to talk about 5 things which I think are so relevant to force management, but occlusion in general. And so let me give them to you one by one, starting with something that's like really low-hanging fruit. I use that word when we are talking on Instagram. Like, I want to tackle the simple things that no one talks about that has a disproportionately large leverage effect on your application of occlusion, because that's what occlusion is. Occlusion is not looking at funny images of condyles in the fosse, right? Occlusion is practical, getting your burr out and doing something to make it all work.
And not just blindly burring off all the blue spots, like being intentional about it, right?
100%. That's point number 2, and we'll definitely discuss that. I love your word, intention. Oh, yeah. And so already you're thinking along the right path. So number one thing I think that makes a huge effect, and such a stupid and simple thing to do, Erica, right, is if you have a patient, like, let's say you're doing some bonding of the upper incisors. Let's say you're doing lateral incisor to lateral incisor, 2 to 2, or as they say in US, I think it's number 8 to 10 or something like that, right? I think in different countries, different ways of saying it. But lateral incisor to lateral incisor, you're doing some ceramic veneers or you're doing some composite. And usually they're doing it because there's been some wear on the edges, right? They're not looking so good. Now, I see it all the time. I've done it before, where you put these beautiful veneers on, okay, and then you check the occlusion and think, okay, that's all looking good. But if there's wear on those upper incisors, usually there's also wear on the lower incisors. You agree?
Yep.
And what do lower incisors, when they have wear, what words could you describe what lower incisors look like when they're a little bit worn?
A little bit like shovel-like.
Yeah. And then and their shape is like these like pointed corners.
Yeah. Like it kind of comes up, right? Like divots up.
Yeah.
Mm-hmm.
Divots and sharp bits. If you get a glove finger and you run it along, they're sharp. So we've solved the wear at the top, but we're leaving those lower incisors. I'm not saying like restore them, right? They may not need restoration, but leaving those sharp edges, right? It's like I say to patients, it's like having a sawing effect on your upper teeth. The first person who taught me this was like 10 years ago into a lecture by Ed McLaren, right? Famous dentist from the US, okay? And he showed routinely, he didn't like talk about it, but I routinely saw in his pre-op and post-op images, he did all these beautiful veneers at the top, and the lowers, he placed this incisofascial bevel. And I approached him at the end, I was like, wait, I've noticed in every single one of your cases, you did this incisofascial bevel. What was this about? And he explained it to me. Look, you can't do beautiful stuff and then do nothing to the lowers. You can't just leave sharp edges and corners. It's not going to work. You've just restored the uppers and given them full form. And if you're not, doing anything to those lower incisors, at the very least, smooth them. So what I've been doing for many, many years, and patients love it, and it's about communication as well, right? I tell my patients it's like a manicure. I'm going to manicure your front teeth. And I even get them, look, can you feel with your tongue how sharp your lower incisors feel? They're going to have a sawing effect on these lovely, beautiful composite or ceramic restorations that you spent so much time and money on, right? So what we're going to do is we're going to give you a manicure. And honestly, like dentists, when I mentioned this the first time, they get a bit nervous about this. Are you starting to get a little bit nervous about this?
I can see where, the idea of touching the bottom ones can be daunting. Yeah.
And dentists ask me, like, do you need LA? No, you don't, right? And what aren't you adjusting away the occlusion? Well, actually, let's talk about this for a second. When you put the articulating paper mark on these lower incisors, okay, is the MIP contact? Let's just calibrate, right? What I mean is tap, 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 okay? Tap, tap, tap. Is the actual loading surface of that lower incisor the sharp bit? Hell no. Because if it was that sharp bit, it would have been flattened and it would have been smooth. And so those are useless bits. They're not contributing to your occlusion. They're just there. The patient has carved these areas over time, right? And therefore, the worst thing we could do is leave them there. So you get out your Softlex, you get out your coarse Softlex disc, put it in the backhand, and then just go around, no local anesthetic needed, and just smooth them. And then you tell the patient, have a feel of that. And they're like, oh, wow. This feels great. And the way to check is with your gloved finger. But this, no one talks about this, but in terms of long-term success for your bonding, like you get those chipping of the lateral incisors, or you get like little bits breaking away at the edges on your composites, for example, right? How much of that could be because there was not enough care and love given to those poor lower incisors?
You're making me think about it now, Jess, because literally just on Wednesday, I repaired a chipped composite veneer for a patient who had it redone a month ago, who from there it had like chipped from when the last time she had it done. And so we just keep restoring it. But now I'm wondering, I was checking, Canine guidance, I was checking all the other stuff. But like now I'm thinking, I'm like, did I even look at the lower incisors? And I wonder, could that have been a contributing factor? Can I pick your brain a little bit more, Jazz, when you were saying that facial incisal edge and how, just beveling it, how much are you taking off and at what angle are you doing it? Are you reducing the incisal height of it, or what are you adjusting?
That's a great question. Okay, so the anatomy of a lower incisor, right? You have the trailing edge, which is the lingual, right? The lingual, that often you get that fracture of the lingual, of the lower incisor on the lingual side. So that little sharp, often the tallest part, is that lingual bit. So if you imagine rubbing your finger on the lingual surface of a lower incisor, then you reach that first sharp bit as you come onto the incisal edge. That's the trailing edge. Then you have the incisal table, which is the flat bit. Often that has a bit of a slant to it. And then you come onto the labial. And as you transition from the incisal edge to the buccal surface, that's the leading edge, right? And so essentially what you want to do is you want to identify, is there anything sharp and pointy on my lingual or trailing edge? And you just go ahead and smooth that. Then you check the actual the incisal table, the actual edge itself, right? Is the transition from the lingual to the incisal nice and smooth? You don't want any like peaks and like pointy bits. And then lastly, that incisor-facial, which is very important because that's the leading edge of the lower incisor, right? As you're chewing, it's usually in a class 1 or class 2 patient, that leading edge of the lower incisor, which is the labial, right? The labio-incisal, that's the one that could be crashing into your upper restorations. So all you have to do is take away enough so that it's not sharp, and really it's not much. If I was to show you a before and after image, you'd be like amazed, like, oh wow, is that how subtle it is? And my measure of success is when I take my glove finger and it just feels smooth to me, right? Now, there are some nuanced cases whereby we're kind of pushing the boundaries, and this patient really ideally would have benefited from some ortho because they're kind of tight. A tight bite, you need more overjet, right? In that case, on a patient who's old enough, you may choose to then get like a red grit diamond out and do a little bit more, like Ed McLaren first showed me, do a little bit more. And so what we want to do, and you asked a wonderful question about the angle, right? So you want to make the angle of the bevel, the facial incisal bevel, in that more advanced case when there's not enough overjet, and you really want to program in a little bit of a wiggle room, a little bit of space, a bit of breathing space for those lower incisors. And you want to put that burr up against the upper incisor, right? The sort of lingual, right, of the incisal edge, get that angle and transfer it onto your lower incisor. What that does is a phenomenal thing, right? Here's what that does, right? When you then put your articulating paper and you get the patient to grind forward and back, it's going to show you these lovely, broad articulated paper marks, not chicken scratches. It's going to give you lots of area. And why is that important? Because surface area, okay, when you're like standing on one nail, that nail's going to perforate your foot. When you're standing on a bed of nails, right, you can do it. So if you can spread the load even on one tooth, instead of it being concentrated in a sharp chicken scratch line, you already are now applying force management protocols. You're already applying the practical elements of occlusion. Does that make sense?
Yeah, absolutely. So when you were saying like in those patients that have, could probably benefit from a bit of ortho, immediately what jumps to my mind are the patients where the teeth are like crowded and you have one that's a little bit higher, one that's a little bit lower. Are you referring to those kinds of cases where you would measure it with the top teeth and then transfer and just even those all out or create space? Are you respecting still? Yeah.
Yeah, I think that helps in those scenarios. But the actual case I was referring to in that regard is more when you need ortho to give you more overjet, right? Like if you do upper veneers and the lower incisor is just right underneath it, almost edge to edge, but they're just shy, right? And you know that every time they're chewing, every time they're grinding, like it's a near miss, or they're touching, they're rubbing very harshly. And in an ideal world, like if I often do this in my workshops, right? If your life depended on it, Erica, and you had to give your patient a lifetime guarantee of your upper veneers, right? If your upper veneers and they needed to have a lifetime guarantee, or the day the veneer fails, you die, which kind of patient, which occlusion patient would you choose?
The one that's very class 2.
Either the severe class 2 div 1, but even then they might then fall and break it, okay? Or the anterior open bite.
That's true, actually, yeah.
So if you and we can learn so much by looking at our patients, right? The only patients that still have their mamelons intact, right, are our anterior open bite patients, right? Even into their 40s. And so you have to think, right? There's a reason for all this, okay? So that's an extreme example, right? But it helps to serve a point that the opposite of that is when you have a deep bite or you haven't got enough space. In that scenario, you might wish to give that incisorofacial bevel, which is a bit more advanced than I want to talk about. But it's great we go down this rabbit hole. But the main takeaway point, guys, is get that soft flex. Don't be afraid to get that soft flex disc out course on the backhand. And as long as you're getting from sharp to smooth, that tiny little detail, I think, makes a big difference. There's no evidence to back it up, but this is practical occlusion. In a practical occlusion, there's very little evidence, but as long as it makes sense in terms of force management and you're not mutilating the teeth, these are little details that can really make a big difference.
Yeah, absolutely. Like, I love that you gave the analogy of like a manicure, and I think those little things help put things into context. Like, you do all this work on the top teeth, but then if you're putting it into that same environment and these bottom teeth are not favorable and not serving it, then what's to say that it's not just going to break away again? There's a lot that comes with leaving university and properly adulting that no one really prepares you for. As a new grad with an income and newfound responsibilities we don't know what to do with, managing finances can be really tough. That's where JS Medical and Dental Finance comes in. Specializing in financing options tailored to medical and dental professionals, JSMDF is a completely independent broker dedicated to finding the best bank and lender for your unique situation. Led by the incredible Jason Savage, who personally came to my rescue and worked his magic and helped me secure a loan before I even started working. JSMDF is committed to supporting you throughout your personal and professional journey in whatever way you need. Whether you're looking to buy a house, a car, a practice, or pay off that year-long CPD course you signed yourself up for, JSMDF offer comprehensive advice tailored to your short and long-term plans. Their goal is to be with you from day one and thoroughly understand your financial needs and provide solutions that best work for you. And so if you're looking for some advice or you simply want to explore your options, get in touch with Jason and his team. A big thank you to JSMDF for helping make being an adult that extra bit easier and for supporting the graduate dentist community. Yeah. What's number 2? Tell me, Jaz.
All right, number 2 is, so Erica, do you use shim stock foil?
Yes, but I would love, I would like to have a better protocol and be more intentional with why I'm using it.
So let's talk about this. So shim stock foil, for anyone who doesn't use it yet, is 8 microns, right? So it's super thin, right? And it doesn't ink, so it's just a foil. And the reason for that is, let's say you're doing a lower first molar restoration, and you are conforming to the bite. Like the bites, you're not raising the vertical dimension. You're just doing a simple class 1 restoration on a lower molar. And what you don't want to do is get in a scenario where you're not sure what the initial occlusion looks like. You need to know what the pre-op occlusion is, because then when you come to adjusting, how do you know when to stop? You stop when you've achieved the same occlusion that you had before. And I know it sounds really simple, but the classic mistake we all make is we go in LA and we start removing the caries and we then put the composite and then we check the occlusion at the end. But actually, we need to just, while the LA is happening or just before, just check the occlusion. It takes seconds. And all you need to do is put the shim stock foil on the tooth behind, so on the second molars, and the tooth in front. And what you're going to feel when you try and pull it is a tug. It's a hold, right? And therefore, you know that the tooth behind is touching in the bite and the tooth in front is touching in the bite. And so then when you've done your composite and you get the patient to bite together, if you put the shim stock foil now on the tooth behind and the tooth in front, and you know that it's pulling out, you know automatically that your restoration is proud, right? So that's one common application of shim stock foil, and you keep adjusting it, and you don't ask the patient, how does it feel, right? They're the last point of sort of data for if your occlusion is right, because they're numb, their mouth's been open. You need to do your own checks. Things like how does a bite sound? There's a sound when lots of teeth are hitting together that gives a very distinct sound. That is more important than how does it feel. How does it feel is the very, very last thing we check. So until your tooth behind and tooth in front is now holding shim, you know you have adjustment to do, and then you are correct. In an ideal world, the restoration that you just placed, that class 1 composite, is also, should you desire, and usually you would, contributing to the occlusion. Again, it's like the bed of nails. You want one more nail. The more nails you can have, the more distribution of load you have. But the main point I want to make with the application of shim stock foil, yes, in day-to-day dentistry, it helps. But the key thing that's going to make a big difference to your crowns fitting the next day, right, or the few weeks' time, is the following, right? When you send the crown prep to your lab technician, let's say we're scanning, and then you send the digital scan of the bite, or you send, let's say, a paste bite to your lab if you're working analog. When you visit the lab and you see what they see, it just blows your mind. You'll never see it the same way again, right? I went to my lab and I saw him, and a very talented technician, and the cases he was getting, when he put it on the digital articulator based on the scan, according to that digital articulator, only the upper left 7, let's say, and the lower left 4, so only the second molar and first premolar were in contact in this patient's bite. And so what he had to then do is he had to digitally calibrate. He had to actually bring the models down to make all the teeth come together to then do the crown. And to make it even more tangible, because sometimes it's a bit abstract, what I'm trying to say here is the occlusion that ends up in front of your lab technician is not necessarily the occlusion that's in your patient's mouth. The best way to get crowns that fit is actually in your lab prescription, as well as saying Emax A3, just say, these are my shim holds. So you'd say, so let's say you're doing a lower left first molar onlay. You would say, my shim holds are upper left 8 against lower left 8, upper left 7 against lower left 7, upper left 6. So all the teeth that are contacted. You might find that actually when it comes to the lateral, comes to the premolar and canine, they're no longer holding, but they're dragging a bit. And so when the technician then checks the occlusion for the models that you just sent, and they're noticing that actually only the upper left 6 and upper left 7 are in contact, holding shim, he knows to close the model some more until he's now replicated your patient's occlusion. Then when he makes the crown now, it's actually going to fit. Because so many times they're working with the error that's been sent in scanning, or the error that's been worked, that's been sent with the paste bite, for example. There's been a huge error, and that's why our crowns often come back proud. Does that make sense, Erica?
Yeah, absolutely. But I'd never thought of that before, because I think we take a bite scan and then we think, okay, I've taken that, so surely it's going to be exactly that when it goes to our technicians. And I feel like I've spoken to people where they're like, oh, do you take both sides? Do you do it before your prep? And so I feel like the fixation has always been on, doing that and trying to maximize the accuracy of the scan. But I love that you're giving your lab a second point of reference. It's not just the scan, but it's a verification. It's a verification, right? I'd never thought of that before, but that's so interesting. That's really fascinating. So, and I hadn't
since I've been doing
that
this with a technician, it just comes back fitting in well, and quite often, you see this all the time. Like, for example, when you have a patient with a really standard bite, the kind of bite that if I gave you an upper and lower model and I said, Erica, bring these models together, they're so cuspy, and that they've just finished ortho, for example, and everything just beautiful class 1, it just fits together so nicely. There is no other position, right, those models will fit. They'll go straight to their home. In that kind of patient, you don't need a bite scan, to be honest with you, right? When you fit the models together, there's only one place they fit. The reason I mentioned that extreme scenario is the other extreme is the kind of patient where you bring those two models, the upper and lower model, and you try and fit them together, and you have no idea how they fit together. There's probably 7 different places that, is this the bite, or is that the bite, or is this the bite? Those are the cases where the shim holds and photos are so key, so that the technician can put it together the exact way the patient's masticatory system has allowed those teeth to come together, so that you have some hope in doing as little adjustment as possible as fit when you fit the crown on that day.
So you mentioned just then, you said the shim hold points, but also photos. Are you sending specific photos of the bite to your patient, to your technician?
In a case, for example, think of that anterior open bite patient. What do the molars often look like? You know, third molars, second molars, first molars on an anterior open bite patient in their 40s.
Quite worn down and flat.
Very flat, worn down. They're like sliding around. They can like, if they move a little bit to the left or the right, they'll probably still have a bite of some sort, right? And so you can see you're constantly chasing a moving target. So in those cases, right, if you're not scanning scan will obviously send away some images and whatnot, right? But to actually supplement those more tough cases with as much data as you can, it really helps. Send them a photo of the articulating paper marks, even if it's intraoral images. This can really help. So the more funky the occlusion gets, the more data we need to give our technician.
To help them verify. And then the follow-up question I had for that was, so you would take, with our obviously blue articulating paper, seeing those bite marks, taking a photo of that, sending that to the technician. But then when you mentioned the shim stock hold points, how many points of reference do you think is good to give? Like, is there just as many as you?
At least a quadrant. But if you've got like, okay, so here's what technicians love, right? Here's my technician loves, and what he would wish that I'm going to pass on to you all, and I'm going to do it in Graham's honor. And so they prefer full arch scans. I know we do quadrants. Like if you're doing one molar on the lower left, they actually prefer a full arch scan. Right. So even though you select quadrant on your scanner, they would much prefer it just gives them stability all the way around to bring those models together. So they prefer more data. And if I can give him the full shim holds, the whole mouth, because let's say this takes an additional 20 seconds, he would love that. He would actually love that. And so that really helps to seat it properly. So if you can give the full arch, if you can give the entire mouth of shim holds, but when we're conforming for a direct restoration, we're doing a composite on a molar, all we really need is a tooth behind, the tooth in front, and one tooth on the other side. And that's it. And so you've conformed, as well as what it looks like, as well as what it sounds like, as well as putting your finger and feeling the premitus. So, I mean, we can go down all these different ways to verify you've conformed. But shim holds is absolutely a game changer. And such a stupid little thing, right? It's like thin piece of paper, foil, and it makes a huge difference. Now, we talked about Arctic paper at the beginning, and I want to just reserve it for this number 2 as well. When you're using Arctic paper, when I ask dentists, how thick is the Arctic paper you're using, they have no idea. They're like, whatever my nurse gives me, okay? Do you know, Erica, how many microns your Arctic paper is?
40 microns.
Amazing. So at least you know. I'm glad, okay? So if you have a occlusion and you put 200 microns of paper on it, and let's say the restoration's proud, what kind of marks would you see?
If you had 200, really broad marks on everything.
Yes. Big, broad marks. And so when you pick up the burr, you're going to go, you drill away like 3 millimeter squared surface area. But if you were to use, my favorite thing is like 12 micron troll foil, or I love Parkel, which is like 25 microns. It just, not just how thin it is, but how it inks. It inks really nicely. So when you check with like 25 micron paper, bite together, you're going to see a 1 millimeter square, as an example, compared to 3 millimeter squared. And so how much more precise are you being, right? You're not mutilating that tooth or restoration. You're just removing the actual part that's proud and not the bits that aren't proud. You're actually keeping the anatomy that you worked hard to create, but you're literally just removing the bit that's proud. So using thinner papers is recommended. So my top takeaway here is, yes, use shims. At least know what Arctic paper thickness is. 40 microns and less is recommended because it'll allow you to be more precise.
Mm-hmm. Even when, like, just building on from that, being precise, Jaz, with using your articulating paper, do you have any other tips on how to get that really, I guess, those marks being really clear? Because oftentimes I'll notice, like, if I haven't dried it enough, then there's saliva on it and they bite, and then the patient swallows and it disappears, or sometimes I feel like it smears around. What do you feel like is the best way to ensure that, like, and verify that these blue marks are true blue marks?
I love the word, use the word true there, because you get false marks all the time. And then if you don't think about that, you see all this blue and red and you just, you're getting rid of it all. You're not serving your patient in any way. You're getting rid of their own anatomy. You're introducing so many occlusive discrepancies down the line. So if you're not getting good markings, then number one, get some miller's forceps, right? And put some tissue paper in between, like fold and fold and fold, so it becomes like a little rectangle, and get the patient just bites on this tissue, like not like the Kleenex type tissue, but like the kitchen roll type, you know, the ones that we all have in the clinic, the tougher tissues, and then that immediately wicks away or absorbs all that saliva, and then introduce the Arctic paper. That makes a huge difference in itself. The other thing you could do is you can actually use the thick Arctic paper first. That will then give you like a blue background, and then you can use your red over it, and then the red over the blue will allow you to see it better and see it clearer. So it's ink on ink. That's another way to do it. And lastly, another technique is that if it's not marking, or let's say you got some restorations, PFMs or whatever, and you're finding that it's not marking well, you can a very thin, very, very thin, guys, bit of Vaseline with a microbrush. That Vaseline will allow the ink to transfer a bit easier.
I love that. I love the paper towel trick. I'm just like, whoa. I love these like simple things that you can do, which is not necessarily going and buying some crazy new material or technique. It's just utilizing what you have, but to make your life a little bit easier.
You can buy Gulati paper, which is like pre-assembled in a perfect rectangle for you to put in your miller's forceps. No, I'm just kidding. So yeah, you don't need anything fancy.
Buy now, it'll be cheaper, right? Oh, amazing, Jaz. I love that. I thought that was a really great, again, practical tip. Shall we move on to number 3? I often say on the podcast that the more I do, the more I realize just how little I know, and how dentistry is just one of those careers where you never stop learning. But let's be real, getting the right training can be expensive, time-consuming, and sometimes just straight up overwhelming. That's where Ripe Global comes in. Founded by Dr. Lincoln Harris, Ripe Global is completely changing the way that we learn. They offer immersive, hands-on training that actually fits into your life. Whether it's through improving your preps, getting faster with composites, or tackling more complex cases, you'll be learning from some of the best clinicians in the world without having to take time off work or spend thousands on travel. And so if you're serious about upskilling and boosting your confidence in the clinic, check out Ripe Global today. Hit the link in our show notes and let's start learning smarter, not harder.
Yes, I'm going to ask you at the end. Which one was your favorite. So yes. There we are. So first one was smooth those lower incisors. Second one was shim holds, but also a little bit on Arctic paper. Mm-hmm. Number 3 is a concept that, you know, there's very few things, Erica, that I've coined in dentistry or occlusion, right? Everything I teach and share. Yeah, there we are. Everything is like, with blessings from my mentors, plagiarized or shared, or like, you know what, I've had permission to share this from Michael Melkers, or you know what, Frank Spear taught me this. I mentioned Ad McLaren. Every time I learn something from a mentor, I want to share with everyone. But I'm pretty sure I came up with this one, all right? And this is Robin Hood dentistry. Have you heard of this concept?
No, but I'm assuming it's got something to do with taking from somewhere and giving to elsewhere.
That's it. Okay, yeah. So here's a common scenario I see all the time, which really confused me when I was a new grad, right? Have you ever seen a lower molar? I don't know why, it's often the lower left second molar, right? But it's a lower left second molar. And you look at it and there's like, it's exposed dentine, like on the distolingual part, right? And you want to, like, this is begging for restoration. Like, it's completely broken down. There's an old amalgam in there. And there's a huge, like, a cavity, 3 millimeter depth cavity in this tooth. And you think, oh, I want to restore this. But when the patient bites together, you have no occlusal space.
Oh, absolutely.
Have you seen that?
Yeah, 100%. You're like, what do I do now?
And so what can you do? And if you go back to literally what can you do? You can extract the opposing tooth. Now you can restore it. That's a stupid thing, right? Because you've lost function there. Okay, that's not great. You can do orthodontics, right? You can literally do orthodontics, put some TADs in, intrude that second molar, and now you have space. It's all about occlusion is a game of space. And so now you can gain the space to restore. Now, let's say the patient has perfectly aligned teeth. They're in their 60s. Is ortho really the most minimally invasive thing you could do to move, activate their osteoblasts and osteoclasts and put them in a lifetime of retention, all that kind of stuff? I think that's not minimally invasive for that patient. Robin Hood dentistry shines here, okay? The opposing cusp that sits, it's like a plunger cusp. It sits in that cavity, right? If we steal from that tooth-rich substance and give to the poor lower molar, right? That's it. We can solve those cases. I've got years and years of follow-ups of these cases, right? Whereby and here's what you shouldn't do. You don't amputate. There's a specific way to actually smooth that cusp. So you're not like making a plunger cusp and you're flattening it. Okay, that's not good. You want to make that tall, aggressive cusp, and you want to make it a smaller cusp. So you're transporting it apically. What that does now, it gives you that golden 2-3 millimeters to now restore that lower molar. You still probably don't have enough to give you, 2 millimeters thickness of Emax, but very often those scenarios, I will go for like a metal, like cobalt chrome or a gold restoration, and to have that in 1 millimeter thickness, it works beautifully. And so always remember to when you're assessing for restorations, it could be any restoration you're doing, always look at the opposing cusps. Is the reason that restoration failed, or is the reason this tooth broke because there's an aggressive cusp opposing? And if so, identify it now. Because what you don't want to do is at the end, tell the patient, oh, actually, the occlusion is completely off. And if I reduce this restoration anymore, there's not going to be anything left anymore. So I need to remove your opposing cusp. That's not how it works. If you identify it beforehand, say, hey, patient, you have a really aggressive, can you feel it with your tongue? It's like, oh yeah, that's really aggressive. We're going to do some Robin Hood dentistry. We're going to steal from the rich and give to the poor. And patients get it. They're more, they just get it, right? And so utilizing the Robin Hood dentistry concept, it can actually solve a lot of cases.
Absolutely. Can we dive into how, when you mentioned before, like just shrinking that cusp and lowering it, but still respecting the shape and the anatomy of it, not just amputating it and flattening it completely. How are you going about doing that? Are you using particular burrs? Is there, a way that you're rounding it off? And how much can we take off before we know that? Well, I assume, again, perhaps similar to when we talked about lesson number 1 about smoothing off the lower incisors. I imagine a lot of us would be scared about like, oh, what happens if they get sensitivity? So how much do you do and how do you do it? Mm-hmm.
Great. And so I'm glad you mentioned sensitivity. This is the number one concern I get from dentists when I talk about this. But that patient is often having a sensitive lower second molar. Because actually that's like that lower molar that often that's broken down I've described is probably 2.5 millimeters away from the pulp, from the point of dentine exposure. That tip of that plunger cusp, right, is like, I don't know, 7 millimeters away from the pulp, like especially in a 6-year-old or something, right? Because look, these things happen over time. The tooth wears, the opposing tooth erupts, the tooth wears away some more, and so by now the upper molar is actually extruded a tiny bit, it's tipped a bit, and that plunger cusp is like really rammed in there. And at the same time, the pulp is receding. The pulp is actually sclerosing away. So I've never had it where I've done this and the patients come back saying sensitivity. In fact, the patients are grateful that I've solved the source of sensitivity, which is from the lower molar. But we need to still ideally remain in enamel. So usually you're very enamel rich on the cusp tip. And the way to do it is you need to do a little bit of sweeping motion, right, on the palatal incline and a little sweeping motion on the buccal incline. So basically either side of it, you're just doing a bit of sweeping motion. And where they connect in the middle, you're rounding it off. What you're then therefore doing is you're respecting the fact that it still looks like a cusp and not flattened. What not to do is take your burr and go bzzz, like a occlusal reduction or something. You have to go from one incline and the other incline and then join them together. That's how you transport that. And a little bonus tip, which I think no one talks about, but I think is really important, is you also have to think about which direction do you want the future contact to go, right? So for example, an upper molar palatal cusp, right? It sits on the fossa, or in this scenario, probably a little bit mid fossa or slightly lingual to that lower molar, right? And so you ideally want that future contact, that dot that it provides, the bite that it provides, to be more towards the middle of the tooth. So what you're going to do is you're going to sweep more on the palatal side of the upper molar to actually move the cusp a little bit more towards the buccal to allow it to sit more in the middle of the tooth and not in the way of the cusp. So this is like something that you when you start doing adjustments and articulators and that kind of stuff and equilibration, this is where the magic really happens. That you realize that actually by just sweeping a little bit more here and rolling the cusp, we call this rolling the cusp. If you roll the cusp a little bit more, you can actually transport the MIP contact. Does that make sense?
Yeah, absolutely. I find that just the way you describe it, I'm imagining you're almost like working with clay, or perhaps it's like when we do place our composites, right? It's like, oh, which direction do you push your composite to shape it in a particular way? And I guess in this case, you're carving it so that you reshape and reposition the tooth or the tooth cusp to be in a more favorable position. But I really like your tip about, because I know I've been guilty of, oh, there's not enough space or whatever it is, and you just lop off it from the top of the cusp tip, but just taking it from the sides and then rounding over the top. Again, I think intentional.
And you also asked, yes, intentional, purposeful, measure twice, cut once, that kind of stuff. But you mentioned how much. Well, that area of enamel often is unworn because all the wear happened on that lower molar, and such a sharp, pointy cusp. Again, that cusp tip is far away from the pulp. Quite often, you can get away with 1.8 millimeters there because it's still going to stay in enamel there. Now, the enamel's getting thin there. I appreciate that. But it's still like, even if you're close to dentine, how long will it take that patient to actually wear into dentine there? And especially if you put a cobalt chrome crown material, okay? If you go for a cobalt chrome crown or a gold, that wears away at a similar rate to enamel anyway. And now that you actually fix the equation there, and you've got a well-distributed arch otherwise, I don't see a reason why that tooth would, or that point should wear away at an excessive rate if you've now balanced it out. If you don't do anything, you know for sure that lower second molar is going to need an endo. And guess what? When it needs an endo, you still won't have enough space to restore it. So it's a vicious cycle.
Yeah. You mentioned that it's often your upper molars, like palatal cusp, that ends up being that,
Yes.
The tilting and the plunging. Do you ever find any other key teeth that you would keep an eye out? Or is it usually
any teeth that are a little bit rotated, so it could be upper premolars that are a bit rotated, that palatal cusp and upper premolar can do that as well. But classically, it's the palatal cusps, the mesiopalatal cusp of the upper second molar or first molar, or sometimes a premolar. Those are the most common ones I see. I've also seen it whereby the lower first molar, distobuccal cusp, in those scenarios where they maybe lost a premolar in their younger years, and the tooth has, and it's tilted more towards the sort of mesial, and that mesial tilt, it rides up that distobuccal cusp, and that can also be the source of the issue.
Understood. Food for thought. I love that. That's really good, Jaz.
Great.
You all know that if there's one thing I am super passionate about and always advocate for on our podcast, it is our mental well-being as dentists. There's no denying that our profession can demand so much from us, and it can drain us physically, emotionally, socially, and mentally. And some days it can all just feel a little too much. This is where our friends at Dental Practitioner Support come in. Whether you're new to dentistry or have been practicing for years, Dental Practitioner Support is here to offer guidance, reassurance, and a safe space to talk about whatever it may be that's weighing heavy on your heart. They provide 24-hour services that are completely confidential and independent, so you know that you will always have someone to turn to. Whatever your scenario may be, Dental Practitioner Support is just one call away. And so, in case you ever need it, save the number 1-800-377-700 or visit their website at dpsupport.org.au. Remember, as we say time and time again on the podcast, you are never alone, and we really are all in it together.
And this one's like philosophical. It's not really practical as the other ones have been, but if it can be definitely applied when anytime you're doing case planning, right? And all it is there are 4 ways that restorations fail mechanically. That's it. There are 4 mechanical causes of restoration failure. Nothing more, nothing less. Okay, I'm going to just break down each 4. And when you get this, then you really get it. Okay, so number 1, okay, is you, the dentist, did something stupid. Let's let our egos go. Okay, we did something stupid. Okay, so for example, something will fail mechanically because we gave them a mamelon and they were a hawk, right? And we gave them a mamelon and tried to be sexy and stuff, okay? And as soon as the patient went out, they bit together on their edges and it just fractured. It sheared off, okay? Or like we gave them 0.7 millimeters of occlusal reduction when we should have given 1.5 millimeters, right? And you're nodding because you've had a restoration fracture like this, right?
Mm-hmm. 100%.
So one mechanical cause of failure is we unfortunately did something, and stupid is a harsh word. I'm playing, right? Like we made an ill-informed decision at that moment in time, and we're human, right? But I like to say that we did something stupid. Okay. The second one is your patient does something stupid. Okay, and let's say nail biting, for example. I don't do composite bonding or veneers on my patients who, you look at their nails, and the good thing to do is take a photo, like your DSLR camera, instead of taking a photo of their teeth, take a photo of their nails, right? And then if they're like, are you a nail biter? I say, yes, I'm a nail biter. I say, okay, I would love to treat your case. I think I can make your smile like amazing. I'm excited to treat you, but I can't treat you if you're still biting your nails. Listen, how about you come back in 3 months? Let's check your nails, and if you've solved it and you show me that you want this bad enough, then at least I can do you something that's going to last a long time. I don't want to do this for you and you have to spend hundreds of dollars every month in repair because you keep chipping it with your fingernails, for example, right? That's an example of a patient doing something stupid. And then when they come back in 3 months, if they now got nails again and they've stopped, amazing. You may now have the green flag. It's kind of like you converted a HORP to a LORP in one facet, right? The other one is when patients bite sellotape, or they, ladies with long hair, they hold their hairpin on their, like, inside the edges. These are all stupid things that they can do. And I had this document, like, how to care for your composite bonding. And it just goes through each thing for the patient. Like, if you don't tell our patients, right, they don't think about these things. They're like, oh, I mean, it sounds really common sense, but they just, I didn't know I couldn't chew on ice. Like, you know what I mean? Another cause of failure, like I said, second cause is your patient does something stupid, right? So we do something stupid, the patient does something stupid, and that leads to a mechanical failure. The third one, this is when it gets more into occlusion and very interesting, okay, is you put something in the way of function. The patient, when they're chewing, okay, they're going to knock against that. A really easy way to understand it is when you have a lower incisor, one rogue lower incisor that's a little bit more labial and a little bit over erupted, and you go ahead and you do the class 4 restoration on your upper incisor composite, and you get it to look symmetrical to the left one, and it looks good, you polish it, you're feeling great, you take the photo for the gram, the patient comes back and they've chipped their class 4 composite. It's because they literally have that lower incisor eating up all the space. So every time they're chewing, we have the envelope of function, right? The way they want to chew. And what that lower incisor is doing is knocking, right? It's high frequency, low intensity. But it's like it's constantly knocking because there's no chewing space, especially if you want it to look good. So that, yeah, if you'd made that upper class 4 composite and you made it look bad, and you made it like shorter by 1.5 mil, so it's not in the way, it's not like knocking against that lower incisor. Or you made it a little bit thinner from the palatal. So again, you have a bit more space. It's going to look bad. It's going to be thin, but it will now work because it actually fits with the occlusion that your patient had. That patient needs ortho to retract that lower incisor to allow you to give the correct anatomical form for that class 4 composite. So the third one is you put something in the way of function. Okay, now that's one example, but that can happen anteriorly, posteriorly, and all that kind of stuff. And the final cause of mechanical failure is you put something in the way of parafunction. So, for example, when the patient bites together and they grind to the right, and that's how they parafunction. Okay, they're sleeping, and they're clench hard, and they grind to the right, and the upper lateral incisor that you want to do bonding on, right? Small lateral incisors, right? We love to do bonding there. And what do we opt for? The patient says, "Oh, I don't want these little gaps between my teeth, the embrasure spaces, right?" And so you close the embrasure. That's where the canine wants to pass through. That embrasure space between the upper lateral and canine is where the lower canine is like an escape channel. And so if you listen to the patient and you close the embrasure space to get a really good look, fine, fair enough. But then because you put something in the way of parafunction, then eventually that's going to break. Yes, you can give them appliance, but the night they forget to wear it, they're putting strain. They're putting overload on that little delicate edge of porcelain or ceramic, whatever you have. So that's it, guys. Occlusion is simple. Don't do anything stupid. Make sure your patients don't do stupid stuff. Don't put anything in the way of function. Actually harmonize with the envelope function, and don't put anything in the way of the envelope of parafunction. Okay, we always talk about the envelope of function. We don't talk enough about the envelope of parafunction, which is essentially how does a patient want to brux. And something Dr. Lane Ochi, one of my mentors, taught me is allow the patients to brux safer. Allow them to brux in a dentally beautiful way. And if you can really grasp these 4 concepts, you will drastically reduce how many failures you will have of a mechanical nature.
Jaz, I'm going to break that down even further because I love that you've mentioned that. But now I feel like, 1, 2, and 3, we're just like, oh, easy, practicable things that I can implement immediately tomorrow. But now with lesson number 4, I feel like you've opened up a can of worms. And my feeling initially when you were telling me those things was, well, I'm going to give up because I should just not do anything. And I think particularly number 2, when you say things that your patient does, and you mentioned nail biting, you mentioned, with a hairpin, things like that, I feel like oftentimes are not things that you said your patient will necessarily think of, but as a dentist, we might not necessarily think of. You mentioned before, like a questionnaire that you have for patients. Like, can you kind of dive into a little bit about like the kinds of things that you would tell young dentists that they should look out for, things that patients do?
How about, like, we'll talk about it now, but how about I make this document available to everyone? I'll send it to you. You can put it in the show notes for them to download. That'd be good.
Yeah, that would be wonderful because I
Cool.
think that would be
I'll pass
one
that over
easy
to you.
thing. Beautiful. That makes me feel a little bit better about that second one. Number 3, I think makes a lot of sense. And actually, the story that I was thinking of as you were telling that was, oftentimes we want to make everything as dentists, we just want everything beautiful and straight. But that's not the way that the patient's mouth is. And oftentimes, if they've got crowding or they've got crookedness, like I think over time their teeth have adapted to be in that particular way. And then we try to go in and make things straight. But if we haven't taken those things into consideration, it's just, what are you doing? And the reason why, what it reminded me of was I had a patient, she needed her lower incisors removed. They're all perio-compromised. She lost them. We ended up doing a bridge for her. And I thought this was such a beautiful bridge because it was just perfectly straight. It looks so nice. I thought the ceramic work was beautiful. The lab technician even put in like pink ceramic just so that blended in with her gums. And I showed it to her and her immediate reaction was, Erica, you've made them too straight. And she's just like, because I've grown up my whole life, I've got crooked teeth, and she's got like, class 2 div 2 where like her upper anteriors like come in and her top teeth are crowded. And then we popped it in. I'm like, okay, I might need to make some adjustments to your bite. And she's like, well, of course you do. You've made them straight. My top teeth are crooked. Of course they're not going to fit together, right? But that was my patient pointing it out.
What a great level of insight from your patient, right?
Yeah. And that's why I said when you mentioned that, I'm like, the fact that my patient had that insight, she's like, of course straight teeth are not going to fit into my mouth. I've got crooked teeth, so you needed to have given me crooked teeth.
Your patient's so cool. I love that. Like this is stuff that, it takes years for someone, should they want to pursue, like to just make it. It's a very simple point, but it's something to actually apply it practically. And when you have like a million things to think about, is sometimes that it doesn't get enough light that it does. And it's such a great point. How can you put something straight in a crooked environment or vice versa? It just arches represent the lower arch. I mean, it reminds me, Erica, of a really cool exercise Dr. Hap Gill made me do. It was one of my first mentors. I was like a few years qualified. And it's so relevant to what your patient said. He gave me a lower arch, a study model of a lower arch, right? And he said, these are lower teeth. I want you to describe to me what the upper teeth look like. I was like, what? I'm not a magician. I don't have a crystal ball. Like, I didn't understand what the question was. Like, wait, what? Why am I doing this? I don't understand. But when you actually look at it, I was like, oh, okay. I see some facial incisor wear on that lower incisor. Oh, maybe they have a bit of a tight bite. Maybe got a deep bite. Oh, the lower right premolar is over erupted. Oh, they're probably missing the upper premolar, right? And it was just really like, that day, I leveled up in occlusion because that lesson was taught to me.
It's like respecting that they are in a position or they are the way that they are for a reason.
Mm-hmm.
Yeah. And then building onto that, I think that leads into your point number 4 about then respect. Okay, so we respected the envelope of function, respected the way that the patient's teeth come together. But then number 4, respecting the way it is in parafunction. How do we check that? Because then you mentioned such a great point where you're like, oh, let's fill in these embrasures so they have nice straight teeth. And then you've just interfered with that way of where their canine wants to glide out when they're grinding side to side. So you said, Dr. Lane Ochi said, allow them to parafunction gracefully. What tips would you have in assessing that level of parafunction, and how do you manage that? How do you know how much to adjust it?
You just have to so you can look visually, you can also do it on models, but essentially when the patient bites in the MIP and they grind to the left, okay, what do you see? Are the puzzle pieces matching up? Like if you have worn flat upper canines, right, and in their normal bite, the canines are like good 4 or 5 millimeters away from each other. But when they go all the way to the left, that exact like wear facet matches beautifully and perfectly on the canines. Well, you know that they spend some time there, and you know they go in that position. So you know that based on the wear facets matching up, that this is the patient's envelope of parafunction, right? So again, Michael Melkus taught me that past is prologue, or the other way to do it is if they went there before, plan for them to go there again. So how could you resolve that scenario? A great example I can do to give you to make it tangible is if you have a worn upper lateral incisor, and then how do you know that's in the way of the envelope of parafunction? Is you get the patient to bite together, grind all the way to the left, and then it just fits together perfectly. And you have no space to lengthen that lateral incisor. And very often we want to lengthen that lateral incisor. The classic mistake we can make is because in the MIP, there's space to lengthen, right? And you build up a 1.5 millimeter or 2 millimeter incisal edge on that lateral incisor. It looks good in the tap, tap, tap. But what we didn't check is, okay, what happens when the patient grinds to the left? And here's another thing, right? Well, a little sidetrack, but it's very relevant. We're going to come back very, very sharply. Is I want you to do an experiment for me, Erica. I want you to bite together and grind left and right, okay? And I want you to tell me, are you canine guided? Are you group function?
Recently, I've been very conscious. I'm very canine guidance on my left. And I rub a lot into that tip.
Okay, and now I want you to do the following. I want you to do the same exercise again. This time, I need to clench. I want you to really activate your masticatory muscles, your elevators, and now do the grinding left and right. Does it change anything?
Yeah, like a lot more of my teeth are touching.
Isn't that group function?
Mm-hmm.
So I've instantly converted you from canine guided, something that's very favorable, to group function. So the reason why I mentioned this is now when we're checking that patient for lateral incisor, we've just lengthened it because we thought, oh, there's space in the bite. I can see that I can lengthen this. But when you check the patient grind to the left, and please do so with a little bit of force, right? Don't just go glide ever so gently to the left, right? Elegantly. And you've got to you allow them to show you what they do in their sleep, for example, right? Especially if they have strong muscles. If they are a hawp, which they often are, because that's how the wear happened in the first place. You get them to grind to left, and then you'll notice that the composite is the only tooth touching now, or it's like really they're locked in that they can't move their jaw because the composite's in the way. You have breached the envelope of parafunction. So you can even do this on a wax up on study models. You go across and the wax will break, or you'll see that, okay, it's really heavy on my wax now. I need to think either ortho or opening the vertical dimension or something to create space. Or another cool way to do it is if you now build a canine riser, so that now we always talk about making things shallower and they're safer. When we do a canine riser, we are actually making it steeper on purpose. I call this like a controlled explosion, right? We're doing a controlled explosion to actually make things steeper, because what we're doing is we are influencing the envelope of parafunction. Let me say that again. We are influencing the envelope of parafunction, i.e. when the patient grinds to the left, we are changing the trajectory of that jaw movement by introducing a canine riser. So before, the lateral incisors were coming together and there was no space. Now you add this canine riser in and the patient grinds to the left, and now everything's on the canine, and you've on purpose done it this way. Now you have the space to restore that lateral incisor, but you didn't have the space in dynamic before. So what you've done here is you've now respected the envelope of parafunction.
In those cases, and I'm so glad you mentioned the canine risers, because again, I'm thinking of a case of a patient where, they've worn down their canines, they've now starting to chip and wear down their laterals. And so we think to build up their canines. I went to a course and they described it as like sacrificial restorations on your canines, these risers. So I'd rather you wear away these composites on your canines than wear away all your front teeth and all these other areas. Would they, and in your experience, do those canines also wear down? Because are they technically also interfering with parafunction, or is it more
they
so?
Are,
I guess
because you
they
planned
are.
it that way.
Yeah,
you
but it's
planned
planned,
it's a controlled
right?
exposure. Yes,
it's controlled. Yeah, I see.
Now, in that patient, if that patient is a hawp and you know that they have attrition due to parafunction, we haven't even entered the erosion debate or mentioned the joints and stuff. We'll save that another time. But in that scenario, you're going to give an occlusal appliance. So you're wanting that nighttime activity, that nocturnal activity, to be applied to your appliance and not to your canine riser. That spares your canine riser. But yes, eventually it will wear away. But that's a success. If things wear away, you've succeeded. If things chip away, you've lost.
I like that. Yeah.
The other thing you mentioned is sacrificial. Another way to think about a canine riser, I'm not a huge fan of, but it's like a fuse, right? When it breaks, it's like electric fuse. There was too much overload, and we're like, oh, thank goodness that failed. We can now fix it and then reset the system, and it protected all your other teeth from the overload. That's another way that some people like to think about it, and it can help in this understanding of it. So it's a controlled explosion. You are influencing on purpose. You're putting on the canine. There are some nuances of how to do the canine riser. I'll send you a video that's on YouTube. You can put in there that literally shows how I do it. It's all about support. What you don't want is just to build the edge of the canine, and the patient grinds to the left, and again, it's going to snap. It's going to bend and snap. You need to build it in a way that actually utilizes compression. All materials are stronger in compression than tensile. So there's little nuances, and often you need to do some Robin Hood dentistry. You might need to smooth that lower canine to allow you to have this correct space and all those things. So a canine riser is a good example of influencing the envelope of parafunction once you've assessed is there.
Jaz, I feel a bit better now. I feel like that deep dive helped clarify things and gave us some really key takeaways of, okay, how we can assess these patients and bypass or manage these certain scenarios. So there is so much we want to learn as new grads that dental school doesn't expose us to. One thing, of course, being the world of clear aligners. But where do we even start? Fortunately for me, I've been lucky to be taken under the wings of Angel Aligner. With over 20 years of experience in innovation and research and over 1 million smiles transformed, Angel stands as the second largest aligner company in the world for volume. With their competitive pricing, rapid turnaround time, and phenomenal support team, Angel is second to none. Last year, I had the unique experience of taking on my very first aligner case whilst undergoing aligner treatment myself, and it is so fascinating being able to experience treatment firsthand and fully understand the ins and outs of what my patients are going through as well. It was such a streamlined process from start to finish. Angel's iOrtho treatment planning software is incredibly user-friendly, particularly for a grad. Their team, overseen by trained dentists and orthodontists, work tirelessly around the clock to deliver your treatment plans within days, sometimes hours, so you aren't stuck waiting around for weeks on ends to deliver your patient care. High quality and with unique scalloped edges that make them both hygienic and super comfortable to wear, both my patients and I have been so pleased with the experience. Thank you, Angel Aligner, for guiding me through the world of clear aligners and for supporting the Graduate Dentist Podcast. Let's bring it home with point number 5 then. What will it be?
I like the use the word home because home is such a relevant word for what we're talking about now. Okay.
Yeah.
So the final one, we're moving beyond single tooth a bit. We're thinking joints. Okay. This is a scary bit where everyone's like, oh, should I continue listening or should I press stop? Okay.
Yeah.
Okay. This is a challenge because this is something sometimes where we can lose our colleagues, right? But it's really important. I'll try my best to break it down. We have our dental home. So those study models that fit together beautifully, right? They just fit together in one place. That's a dental home. The teeth are guiding together and they fit together in a really snug, beautiful position. For many of us, that's our MIP, right? Maximum intercostal position. When you bite together, Erica, you more than likely will bite together in the same place every time. We also have a skeletal, or for our American colleagues, a skeletal home. Right? There's an American dentist I speak to, and she says that when she uses the word skeletal, it sounds more serious, right? When she uses skeletal, it sounds less serious. Anyway, so we have our
skeletal home. I like that.
skeletal home, or another term that I like is orthopedic home, right? Do you know what I'm referring to here?
Tell me. Is it related to centric relation? Or
absolutely.
No?
So the condyles, right, which is like the balls, are now seated in the fossae. You're literally putting the balls in the cups, right? Literally, the balls will sit in the cups, okay? And that is your orthopedic home or skeletal home. Most of us, 97% plus, have a slight difference between where our teeth fit together and where the balls fit into the cups, okay? And that's okay. We can all still survive and breed and populate the world and enjoy our lives, even though we're not perfectly equilibrated in centric relation, okay? Did you know 100% of people who are not in centric relation will die? But it will have nothing to do with them being not in centric relation. Okay, so it's one of those jokes I made that
that's fair.
One of the occlusal camps is that centric relation, this and that. Okay, we can talk about that. But you know what I mean, right? So most of us have a slide, that little discrepancy between those two positions. Sometimes when you want to create space, it's not enough to Robin Hood your way out of it or whatever. You have to increase the vertical dimension. right? So let's say we have a localized anterior wear case and we want to utilize the dial concept, or we just want to do a full mouth rehab because we have severe generalized wear. You can't, there's no space to build the restorations. When you open the bite, you now have space to put your crowns or restorations. The whole thing about opening the bite, right, is where the joint position comes on its own. Like, which joint position do we use? Well, a lot of the occlusal camps will use centric relation because it's where the balls sit in the cups. It's an orthopedically stable position, right? You know that the balls are in the cups. There's only one place it goes. And when the balls are in the cups, you can open and close them a little bit and you can play around with that. And so it is a utility position, what Manfredini calls it, right? It is a reproducible position. It's supposed to be comfortable. There's so many reasons why we use it, but if you lose where you are, you just take them, you put the balls back in the cups and you can just figure out where you are again, right? Very crudely speaking. So the tip I'm going to give is, if you are treating a wear case or you're deciding to plan a wax up and you want to increase the patient's vertical dimension, what classically people do is they send their lab, upper scan, lower scan, and they send the lab the first point of contact, the first tooth that touches in centric relation. Now the technician will see, okay, well, we need space. So what they're going to do, either on the digital articulator or the analog articulator, is they're going to open that articulator and then be like, okay, we're going to open the vertical dimension and put these restorations in. There's a big problem that happens in this one step. The problem is that the way that the articulators open is not how your patient opens. So you have error straight away. You try in the restorations or you try in the mock-up and you got to do some adjustments to get things right. How about, right, we use this little hack that just makes a huge difference. Have you ever used a leaf gauge?
Not very well. Tell me how.
Yeah, totally, right? So I remember doing Dawson Academy many, many years ago, and we weren't using leaf gauges at that point. We were using bimanual manipulation, and everyone's jaw felt so stiff, and we were not moving forward in cases because I was stuck in that scenario. And then I discovered the leaf gauge, and like, wow, this is amazing, because now, right, and this is where it gets very geeky and anatomical, but we'll try and break it down and make it tangible. When you stick a leaf gauge between someone's upper and lower incisors, what are the 3 points of contact that are happening?
Your incisors.
Yes, that's one, and there's two more.
Your condyles.
That's it. Your left condyle, your right condyles. That's it, right? And so what happens then is if I just simply put the leaf gauge in your mouth, Erica, and you're biting on it, okay, then yes, there's some contact in your incisors and then left and right condyles. But now I'm going to say, okay, clench, grind forward, grind back, squeeze together, clench, okay? You're still contacting on your incisors. The force is being transmitted to the periodontal ligament of your upper centrals and lower centrals. But when you go grind forward, grind back, squeeze, the muscles have now done something very clever to your condyles. Where do you think they've taken the condyles? When you're clenching. Back home. I mean, look, it's like when you drop a ping pong ball into a bowl, right? It's not going to like sit halfway up the bowl. It's going to go right in the middle of the bowl. It's going to fall down, right? You just turn that upside down and use your imagination, right? When you put some degree of force, okay, like literally the ball should, if you released everything, it slips back in. So because the muscles have allowed that force to come in, and everyone thinks that, some people think that by doing this, you are distalizing the condyle. And actually, you're taking it, because centric relation is anterior superior, right? It's a specific position. And what if you're going really far back and posterior? Well, actually, if you look at the angle that the muscles go, right? The masseter temporalis, they don't go back. The trajectory of the muscle fibers are going more forward. So it actually is a clever way, and what me and Mahmoud call this a hands-off approach. So the hands-on approach to find someone's centric relation is use your hands. You do the chin point lift or the bimanual, which I don't get along with. Instead, you hands-off. Stick a leaf gauge in, let the patient's own muscles get you in. And you know what? When you do this, grind forward, grind back, squeeze, if the patient hasn't deprogrammed or their muscles haven't relaxed yet, you're still going to be close enough. One thing Ian Buckle taught me from the Dawson Academy, right, is centric relation is a bit like golf. You're not going to get a hole in one sometimes. You're going to get a little bit closer. And the next stage in your mock-up, you get a bit closer. And the temporaries, you're getting, and by the time you get to the final, you're pretty much there, right? You take a 1.5 millimeter shift in your leaf gauge, and the temporaries you do that at 0.1, and the finals you do that at 0.1, and you're there. The balls are in the cups. So the main lesson here is, yes, you got that leaf gauge, right? You found your first point of contact, but now here's where the magic happens, Erica. instead of just getting the lab to open up the vertical dimension by 2 millimeters, because that's how much space you want, how about you just stick some more leaves on, get the patient to grind forward, grind back, squeeze. Now you're like, hey, you know what? I think in this position with 34 leaves inside, I've got enough space to restore that lateral. This central is going to have enough space. I think I'm good here. You scan that bite or you paste that bite. Now the technician puts it on the articulator. They don't have to open or close the articulator. They're literally using that vertical dimension. They're waxing into it. That has reduced a huge opening and closing error, a hinging error. When you now do this, you'll find that you're pretty much there. Very often, I'll transfer the mock-up or I'll do a dial case injection molding with this. A patient bites together, and they're literally like, as though like my magic, there's dots on all the 6 teeth if you're doing a dial, for example, and like you didn't have to do any adjustment to get the vertical correct. Do you see the magic of that?
Yeah, and I love that this relates to our lesson number 2 when we were talking about the shim stock, and like the more information you give your lab, the less you end up compounding those discrepancies. You're like, rather than just giving them the bite scan and saying, open it up to what you think it is, and they're using an articulator that isn't like your patient. In the same way, when you were saying, having a model that's not like your patient, how can you rely and trust that that is going to transfer well into your patient? Well, then if you give them exactly where you want the teeth to be positioned, and they know that's exactly where you want them to be positioned, then you have a lot more of that accuracy and that predictability, right?
Absolutely. I think you hit the nail on the head there. It's reducing that guesswork, either from your technician or the articulator.
Yeah, I'm really glad that you also went a bit further into that, where you're talking about like how many leaves you use, because I guess for some of our listeners, I mean, in uni we never really worked with a leaf gauge, and so I imagine a lot of our listeners don't even know what a leaf gauge is. And listening to you talk about that concept of binding on something on your lower incisors and moving your jaw forwards and back, initially I was wondering, I was just like, I'm sure some people will think, well, our practice doesn't have leaf gauges. Can I use like a cotton roll, or can I do something else? What are your thoughts on that? And I was going to ask, how much do you need to open it up? But it seems that your answer to that was enough separation, but then you can open it up until you have the teeth to have enough space that you're trying to achieve, right?
As a rule of thumb, if you have like a severe wear case, right, and that their upper incisors are now, let's say, 6 millimeters, and you want them to be 10 millimeters, right? If you can get enough leaves in so that you're giving that 4 millimeters of space, you've now opened at the front, 4 millimeters at the front, you've now given that space, and then you can scan that. So it's very well correlated to how much space you need for an aesthetic result. So this is where aesthetics guides our function, guides our occlusion, because it's got to look good, and then we work backwards to figure out, okay, how can we make it all fit together? So a good tip is, okay, if you're lengthening by 2 millimeters, then you've got to add enough leaves in that it gives you 2 millimeters of thickness to work with.
And then I guess kind of just dialing into that exercise that we were saying of binding on your leaf gauge, sliding forward, sliding back. I guess, can we break that down into a step-by-step of how to take that bite scan for your patient? And then do you scan it whilst that's still in? Can you just break it down for us, Jaz?
Yeah, let's talk about the practicalities of it, right? So let's say you want to lengthen the teeth by 2 millimeters. And so it's a mild wear case. You want to lengthen by 2 millimeters. And let's say you're doing a dial. Are you familiar with the dial concept? Aussies are pretty good at this. So you want to restore the upper canine to canine, maybe the lower canine to canine in composite at an increased vertical dimension. And the back teeth will dentoalveolar compensate or overrupt. And then you end up having the right bite. It's a great entry point into full mouth rehab, I think. So I think we need to do more of this interceptive treatment. It's fantastic, right? But it's a good way to, if I just say full mouth rehab, then people get a little bit like wary. But if I say, look, think of it as a dial, you're just building up the front teeth, right? So you want to open up the upper incisors because you want like 2 millimeters extra length. So let's say that this patient happens to be a unicorn and their joints are already kind of seated, okay? So you want to literally add in 20 leaves, bite together, grind forward, grind back, squeeze, and you look from the side and you can see, oh yeah, there's about 0.5 millimeter space around the back, and you get closer towards the lateral incisor, you notice that, okay, there's 20 leaves worth of thickness, which is approximately 2 millimeters. I've got that now. And you get them to grind back, grind forward, grind back, squeeze, so that the balls now go into the cups. You can hold them there, okay, and they usually stay a bit stable, and you can scan the left bite and scan the right bite. If you have a doubt that the patient's jaw is moving around, you can actually squeeze, some paste on left and right, let it set, and then remove one paste, and then scan that side, put that paste back in, remove the other bite, and scan that one. So it gives you another point of stability of holding your jaw if you don't want to rely on that leaf gauge. Then what you see on the scanner in front of you and what your technician gets is upper jaw, lower jaw, but loads of space in between to now build your wax up into, and you are near enough centricalization in that area. You're near enough, and what you're looking for in terms of, you ask for practical nuggets, is how do you know when you're there? Grind forward, grind back, squeeze. You can get the patient to hold on for a little while, a few minutes, and what you're checking for is that there's no discomfort, there's no strain. And then if you're there, then you know that, okay, this is a comfortable position, it's repeatable, because every time you go, imagine you take the leaf gauge out and they went away and they come back the next day, you do it again and the scan should match because it's a repeatable position, because the ball ever only goes in the cup, and it's a very a similar position day in, day out, basically. So it's a very repeatable position. It's a position of utility. We can use it in these wear cases to our advantage, because if we just didn't use that, if we just says, hey, just open up a bit, okay, yeah, let's just scan that, then you don't know how they're going to bite on that day with the increased vertical dimension. But if you can always just guide them with the leaf gauge back in, they're like, oh, okay, all right, this is where I need to bite together. Okay, it's like guiding them to a repeatable position and a reference point.
I really like that. I think the whole concept of the ball in the cup really, like, it makes sense, and that, like, especially the squeezing, I think that was a really good point about, like, when you squeeze, it helps just guide it, or
the elevator muscles do the work for you.
Yeah.
Like we have like we've broken it down a bit. Obviously, like in maths, like, you know, everything when you enter high school, they're like, okay, everything we taught you in like the fifth grade was actually not fully true. There's actually some rules and nuances and that kind of stuff. What we've done today is I'm hoping we've broken down occlusion in a way that's a bit more digestible and gives people, like, you know what, it's just force management. It's about these little things that make a big difference. And I just want people to get stuck in and start doing it. So next time you have a wear case, just get a leaf gauge, buy one, put it in and do it. And yes, what if you're a little bit out of centric relation? You're still better than what you used to do, and send the MIP bite and get the technician to just open up arbitrarily. These little things, the more you practice it, right, the more you apply Robin Hood dentistry, the more you get used to using shim holds, the more you teach your nurse that, hey, from now on, you're going to have a tissue paper rolled up into a rectangle in between a Miller's forceps and bite together. And the more we talk to our patients that, hey, you better not put a hairpin or bite sellotape, or, you know, this is very delicate. When I talk to my patients about composite bonding, I literally tell them, look, it looks beautiful, but it's bits of plastic glued to the edges of your teeth. When they hear that, like, it's bits of plastic glued, I got to be careful, right? It looks wonderful, but tell them it's like nails. When you have it, the ladies, right, when they're removing their retainers, when they've got their nails, can I have that tool, that plastic tool that removes the retainers? I don't want to risk breaking my nails. You got to tell them that these are really expensive nails that you've just done, and you've got your wedding tomorrow. That's how well I want you to look after them.
That's a really good. I love all these analogies, Jaz. I'm also big on analogies, and our listeners hear me say them all the time. But I feel like that one just instantly hits home. And you think about it, and like, people have, you know, these pretty nails, and they last them a few weeks. Like, these ones, you expect them to last you for, like, you know, years. Of course, you have to take good care of them. So that really helps. And I really love, like, as you said, these are all just, I feel like whilst we had those 5 lessons, within each of those lessons, we broke it down into just little steps, little things that you can implement, that none of them on their own are overly difficult. They're not crazy, you know, unicorn ideas that is just, you have to be crazy experienced and have all these fancy tools to be able to implement. It's just
I think the fifth one, I did it in that order, because I think when you start to think about, when you're moving beyond single tooth dentistry, I just want to, like, leave something to inspire people as well, that, hey, you know what, I'd like to do more wear cases. I'm going to get a leaf gauge. I'm going to just practice finding central relation with my patients. That's a great first step. So the fifth one was more to inspire, to be a active participant in your growth, and someone who's actually going to apply occlusion. Occlusion is not the textbook and the mumbo jumbo and the cult stuff, and I mean, it is anatomy, but it's more the application of occlusion that is important.
I really love that. And I guess one concept that kept going through the back of my head as you were sharing all of these lessons, Jaz, is, and again, I don't know where this concept initially came from, but I learnt it from my brother when he was teaching his course. And he often talks about just, like, the trajectory that patients are on, and how oftentimes we meet them at one point and they're kind of going, like, they're obviously their dentition, if we didn't intervene, they would be going downhill. And a lot of times things that we do is just, oh, you've got a worn down tooth, why don't I just build it back up? And all we're doing is just reversing time a little bit, and we're bringing them back up to this point here on the graph. But if we're not considering other things, they're down the track, they're going to keep going down that same trajectory. You're just prolonging it, and it's just this back and forth, but they're still going on that downwards trajectory. But one thing that, throughout all the tips that you shared today, when, from the lower incisors, just smoothing those lower incisors, or, considering their parafunction and how do you ensure that they're parafunctioning in a more favorable way, or looking into their habits. And I feel like almost every single tip that you shared, removing taking the Robin Hood dentistry of taking away from the rich and adding to giving to the poor, it was all not only restoring what was broken, but putting them on a more favorable trajectory so that they're actually going upwards. And I that was, I guess, one thing that I was just thinking throughout the whole podcast. And I think that also perhaps when we talk about our role as dentists, and perhaps to inspire us in terms of the type of work that we want to do and moving forward, it's not only just fixing problems, but also about actually like improving your patients' quality of life and improving their oral conditions. And to perhaps, as we said, hopefully the concept with occlusion is being predictable but being long lasting as well.
We get to also be interceptive, like that Dahl case, localized anterior, but you can't be if you're stuck in single tooth dentistry. Like single tooth dentistry can be very comfortable, but it's so much more fun when you move beyond. And that's why I got into occlusion, because I knew that, okay, I can't do this without knowing about how to actually make things last. And that actually comes from practical occlusion. So moving beyond single tooth dentistry, should you want it, and I think most dentists do, is where the magic really happens. You feel more fulfilled. It also is a source of stress because now you got to do more treatment plans and letters and that kind of stuff. But, nothing worth having comes easy. But enjoy the journey, enjoy the people along the way, and have fun. And fun just comes with actually doing more units, not for financial reasons, but because actually that is the best thing for the patient. That is how you're going to solve the problem for the patient. That is how you're going to get space and have a long-lasting and pleasing smile.
Yeah, wonderful. Jaz, this has been such an enjoyable conversation. I've loved every single
Thank you for having me.
of it. Thank you so much. And thank you guys so much for tuning in to another episode of the Graduate Dentist Podcast. I really hope you've taken something valuable away from this episode, and that you feel heard, you feel seen, inspired, and optimistic about our journey as graduate dentists. As I always say, we're in it together, so let's spread the word, let's share the love, send this to your friends, your colleagues, and those who are on a similar path who you feel may benefit from being part of the community. I'd love to hear your thoughts, so send me a message, and we'll see you again in 2 weeks' time for another episode.